Hello, I'm Michael Freed from the University of North Carolina at Chapel Hill, and I am delighted to provide the summary of PHC 2023 Day 2. We had some really outstanding speakers, very informative. I learned a lot, and I'm sure you did as well. Here are my disclosures, and I would just like to thank all the authors who shared slides for this summary. Without them, they would be impossible. Under HCC diagnosis, staging, and prognosis, Dr. Singhal reinforced that HCC surveillance improves survival in patients with cirrhosis. We're seeing a lot of hepatocellular carcinoma in our patients with cirrhosis from lots of different etiologies, and it's clear that HCC surveillance can improve survival by identifying patients in the early stages when it's still treatable. Today, liver ultrasound and alpha-fetoprotein are currently the best population-based strategy. But there are challenges: patient acceptance, making time for the ultrasound, remembering to show up for appointments, etc. And many studies have demonstrated that HCC surveillance is often underutilized for a variety of reasons. So there are novel technologies that are being evaluated with the goal to improve early detection, along with patient acceptance and decreased cost and improved cost effectiveness. Among those are the GALLOD test, which combines several serum biomarkers along with age and sex to identify patients at highest risk for hepatocellular carcinoma, liquid biopsy technologies, methylated DNA panels, and abbreviated MRI that may have more sensitivity and specificity than liver ultrasound. So we look forward to integrating some of these new technologies into our HCC surveillance strategies. Professor D'Ambrosio addressed the topic of HCC surveillance in patients with cirrhosis from hepatitis C who have achieved sustained virological response. Of course, with the new antiviral therapies, many patients now with cirrhosis, almost all of them, are achieving sustained virological response. And data has suggested that while the risk of HCC decreases in a cirrhotic patient after direct-acting antiviral therapy cure of hepatitis C, the risk is still above the screening threshold, so that lifelong HCC surveillance is still considered mandatory in patients who have had a sustained virological response when they've had cirrhosis prior to being treated for hepatitis C. In Europe, the clinical practice guidelines endorse HCC surveillance also in patients with F3 and those with compensated advanced liver disease who have achieved SVR, independent of other clinical features. There are several factors that may influence the residual risk of hepatocellular carcinoma in patients who have achieved a cure for hepatitis C, such as older age, males, those with diabetes, high liver stiffness, among others, including portal hypertension. But nevertheless, a general safe rule of thumb is anybody who had cirrhosis prior to being cured with the DAA should still undergo HCC surveillance in the future. It's possible that as more data is developed, that personalized surveillance strategies may help with risk stratification, which could help reduce costs and identify perhaps some patients who don't require screening and lifelong screening. But nevertheless, for now, lifelong screening for HCC is still recommended in that cirrhotic population prior to being cured with DAAs. Dr. Papatheodoridis discussed HCC risk stratification in patients with hepatitis B who are well suppressed on nucleoside analog therapies. His recommendations are that HCC risk stratification should be based on HCC risk scores. The PAGE B score, which involves age, sex, and platelet count, is a very simple and well-validated tool, which may be extremely useful in stratifying HCC risk in these patients. It's also important to recognize that HCC risk continues even after hepatitis B surface antigen clearance in those who had chronic hepatitis B, and therefore ongoing HCC surveillance is still recommended. Some studies have suggested that the HCC incidence after post-treatment loss of hepatitis B surface antigen is about 1.9%, while in those who spontaneously lose hepatitis B surface antigen, it remains at about 3.2%. There's a lot of work going on utilizing artificial intelligence and machine learning models that may further refine these risk scores. There is some controversy this afternoon. Dr. Gia was describing the HCC risk in HPV inactive carriers and felt that they continued to have ongoing risk for hepatocellular carcinoma. He also recommended that we should retire the term inactive carrier, which is a historical term that is still used to describe those with low HPV DNA, normal ALT, and no or minimal fibrosis. He describes the small but persistent risk for cirrhosis and hepatocellular carcinoma due to HPV DNA integration. And he really felt that the term inactive carrier leads to a false sense of security among patients with hepatitis B. He recommended utilizing the term HBe antigen negative chronic hepatitis B to better understand hepatitis B disease phases and prepare for novel therapies. But nevertheless, those patients remain at risk, and according to his recommendations, screening is still recommended. Professor Locke took a slightly different approach to answer the question whether HPV inactive carriers are at risk for HCC. She presented data that suggests that the risk is very low, less than 1% after more than 10 years of follow-up, if they are truly in the inactive carrier phase of presentation. And we all know that whether or not they stay that way persistently is often challenging to define. The risk is lower in those who have a quantitative hepatitis B surface antigen less than 1,000 IUs, and the risk is likely even lower in those who remain as inactive carrier phase during long-term follow-up. Once again, defining that and monitoring them appropriately can be challenging. So the risk of true inactive carriers appears to be too low to justify HCC surveillance unless, this is very important, there's a presence of cirrhosis from prior disease activity, of course, or family history of hepatocellular carcinoma or other risk factors. And the risk appears to be able to be mitigated by antiviral therapy for the true inactive carrier, although the data comparing two comparable groups is somewhat lacking. We also had a very special lecture, very moving lecture about caring for patients in war-torn Ukraine that was presented by Professor Banzahali. As you might expect, routine medical care in Ukraine during the war has been severely disrupted. Healthcare facilities, pharmacies have been greatly damaged or destroyed, which is really taking a major toll on the infrastructure of healthcare in Ukraine. The care for patients with chronic liver disease has been especially challenging. Cancers are likely being underdiagnosed because of decreased screening, where there are other more pressing immediate needs to provide care for other patients. Remarkably, despite this, it appears that over 400 organs, mostly kidneys, have been transplanted in 2022 during the war. So I think all of us recognize that aid and support for Ukrainian medical personnel remains of critical importance. There are really exciting evolving concepts in HCC therapy. Professor Rieg talked about stage migration and untreatable progression and updated the BCLC staging in 2022. This has really become the blueprint for how we manage patients with HCC in the various stages. And I won't review this here, of course, but all of us refer to these charts and diagrams from the great work that has come out of the Barcelona clinic. And like I said, really provides the roadmap for how we manage these patients. What you see here on the far right are changes related to some of the newer systemic therapies that are demonstrating effectiveness in patients with more advanced hepatocellular carcinoma. So optimal treatment for advanced HCC and those who have evidence of treatment stage migration after initial therapy really requires a multidisciplinary team and commitment to shared decision-making. She made this very clear. The shared decision-making really relies on working with the physician, the multidisciplinary team, and of course, the patient's values. Factors that come into play in those who have treatment stage migration or present with more advanced disease, of course, involve age, comorbidities, the patient values, location of HCC, availability of certain techniques, and availability of the systemic treatments. So one size does not necessarily fit all, and all of these things must be taken into account as we treat patients with more advanced HCC. Again, it reinforces that ongoing surveillance and early stage detection gives patients still the best chance for curative therapy. Professor Edeline reviewed some of the systemic therapies for hepatocellular carcinoma, and of course, the data from atezolizumab and bevacizumab in studies that compared them to an active comparator of sorafenib demonstrated improved overall survival, improved progression-free survival, and an improved objective response rate. There was improved tolerability as well as improved quality of life. So this combination has really now become the current standard of care for patients who are going on systemic therapies for more advanced HCC. It's also very intriguing to consider whether these systemic therapies can help prevent recurrence in patients with early stage hepatocellular carcinoma. We know that there's about a 70% risk of recurrence even in early stage hepatocellular carcinoma. And at least currently, the ASLD and the EASL guidelines recommend against the routine use of adjuvant therapy for patients with hepatocellular carcinoma after they have had what appears to be successful resection or ablation in early stage HCC. But I guess one of the questions is, with the right agents, can it decrease the local recurrence and provide synergy with the procedures that were performed, or even treat micrometastases and decrease that risk of late recurrences? A very exciting study, the IMbrave 050 study, looked at adjuvant atezolizumab and bevacizumab in patients who were resected or underwent ablation, but were still considered high risk, and the definitions are demonstrated here. And at least from their preliminary results, recurrence-free survival improved in these high-risk patients after ablation or resection. So it's possible that we'll be seeing increased utilization of adjuvant therapies as more data comes out and confirms these exciting studies. This session also looked at some areas of end-stage liver disease and transplantation. Of course, we're still dealing with COVID-19. Things may have improved a bit. It's not in the news as much, and certainly the incidence of the disease has decreased in various parts of the world. But nevertheless, COVID-19 remains important and has demonstrated increased mortality and morbidity in patients with end-stage liver disease. Professor Samuel and Kunis have shown that acute on chronic liver failure is the main driver of mortality in cirrhotic patients infected with COVID-19. Clearly, vaccination is recommended for the end-stage patients with cirrhosis to prevent severe disease, and has been demonstrated to reduce hospitalization and deaths, just like in the general population as well. And they felt that there was a need for additional clinical trials to test the efficacy and tolerance of COVID treatments for patients who have advanced liver disease. Acute on chronic liver failure and liver transplantation was discussed by Professor Berenger. There's very high early mortality in the absence of liver transplant in patients with acute on chronic liver failure, stage 3, as you see here. Multi-organ failure, of course, is associated with poor prognosis. There's a high mortality on the waiting list, but if a patient do get to liver transplant, their survival appears to be quite good. And these diagrams that were shown here are stratified by different ACLF stages. So in order to identify patients with ACLF who may still be candidates for liver transplantation, very important for rapid and aggressive management of these patients, understanding what their underlying trigger for their acute decompensation was, better understanding their disease severity, getting optimal ICU care, and then having a rigorous patient selection process that takes into account the various aspects that are shown on this slide in order to determine whether there could be any chance for survival benefit of liver transplantation for patients with more advanced stages of ACLF. TIPS has been around for many years and has demonstrated a benefit in controlling complications of portal hypertension, and still remains a mainstay of our armamentarium to try to treat poorly controlled ascites, variceal hemorrhage, but we recognize it is not without complications. Therefore, careful selection of candidates for TIPS is important and can optimize its utilization to improve outcomes. The ideal criteria to define candidates for TIPS in the setting of cirrhosis and ascites is shown here. Age less than 65 years, liver-related criteria where they have no history of recurrent hepatic encephalopathy in the absence of known precipitants such as non-adherence to the lactulose and rifaximin, et cetera, and no persistent overt HE despite optimal medical therapy. Child's Pew scores less than 13 and MELD scores less than or equal to 19 will also optimize outcomes in patients who require TIPS. And finally, it's important to evaluate their underlying potential for underlying heart disease, make sure that there's no underlying congestive heart failure, aortic stenosis, or diastolic dysfunction that can impact outcomes after TIPS. Professor Godano provided us with an interesting case report looking at acutely decompensated cirrhosis and differentiating that from acute on chronic liver failure. Decompensated cirrhosis is kind of a catch-all term that covers a heterogeneous universe of patients who have different underlying pathophysiological mechanisms. So it's important to distinguish acute decompensation, such as hepatic encephalopathy, ascites, GI bleeding, from acute on chronic liver failure. This is a well-established phenotype of an acutely decompensated patient with cirrhosis that's associated with systemic inflammation, multi-organ injury, and a very high increased short-term mortality. So if you stratify these patients, a stable decompensated patient with cirrhosis has about a 10% one-year mortality. That unstable decompensated cirrhosis who have multiple hospitalizations has about a 36% one-year mortality, whereas those with pre-ACLF, defined as developing ACLF within 3 months of their index admission, has about a 67% one-year mortality. He emphasized that better predictive tools and treatments are needed for these patients. The gut microbiota seems to be everywhere these days, and Professor Bajaj gave a state-of-the-art lecture looking at the gut microbiota and alcoholic liver disease. We know that there are many factors that affect the gut microbiota that are shown here. Everything from the etiology of the underlying liver disease, the stage of that liver disease, host genetics, diet, medications, comorbid conditions, antibiotic usage, and active alcohol use can affect the microbiota. And the interplay from these, as you can imagine, can be quite complex. He presented some very interesting data that looked at experimental models as well as some clinical data from utilizing alterations in the gut microbiota to affect the outcome of alcohol-related liver disease. Current therapies are not really focused on the gut-liver axis, and we know that they have issues with safety, availability, and whether or not they are truly effective in patients with advanced alcohol-related liver disease, alcoholic hepatitis, etc. He describes why the gut-liver axis is a very attractive target for alcohol-related liver disease, and shown some really intriguing data that the reduction of alcohol intake and cravings in proof-of-concept studies utilizing fecal transplants and probiotic trials has been achieved. Conventional antibiotics have had a mixed record looking at liver-related outcomes and trying to manipulate the microbiota. But even in patients with alcoholic-associated hepatitis, there's some preliminary data that fecal transplant from the nasoduodenal route from family member donations can improve outcomes with alcohol-associated hepatitis. Very, very interesting. So again, he makes a great case for why microbial therapies should be considered as part of a multidisciplinary strategy for the treatment of alcohol use disorders, alcoholic-associated hepatitis, and alcoholic-related liver disease. Well, I hope you enjoyed day 2 of the Paris Hepatitis Congress. We're really looking forward to seeing you next year, perhaps in person. It was a very informative day, and I want to thank again all the speakers for their outstanding lectures, as well as them providing slides for the summary. I'd also like to thank Professor Marcelin and the organizing committee for inviting me to participate. Thank you very much.